Thyroid gland. Goiter, thyroid enlargement. Classification. It's divided into inflammatory goiter, toxic goiter, neoplastic goiter, and simple goiter. Inflammatory goiter or thyroiditis, subacute thyroiditis, de Quervain's disease, autoimmune goiter, Hashimoto's thyroiditis or Riddle thyroiditis, acute bacterial, which is rare, and chronic tuberculosis and syphilis. Toxic goiter, thyroid enlargement with hyperthyroidism, neoplastic goiter, benign or malignant, simple goiter, thyroid enlargement without inflammatory, toxic or neoplastic criteria, and it's divided into simple physiological goiter, simple colloid goiter, and simple nodular goiter. If we're going to compare according to the types, acute goiter, the cause is pyogenic bacterial, subacute viral, chronic TB, Hashimoto and Riddle's are autoimmune. Subacute thyroiditis or de Quervain's disease, etiology, controversial, most probably viral infection, course is remission and exacerbation, onset, moderately abrupt after upper respiratory infection, pathology, thyroid is congested, swollen, with firm irregular pattern, clinical picture, thyroid becomes tender, neck pain, fever and malaise, diagnosis, elevated ESR, CBC, depressed, or even normal leukocytic count. T4 shows slight elevation, iodine uptake by the gland is depressed, and most importantly, rapid response to oral prednisone. Treatment, usually self-limited, but in severe cases we need anti-inflammatory drugs. Autoimmune thyroiditis or Hashimoto, common to affect females at menopause. Etiology, antibodies to thyroid antigens. Onset, variable, insidious, and asymptomatic in some cases or sudden and painful in others. Pathophysiology, at first infiltration of the thyroid gland by lymphocytes and plasma cells. Eventually, acini are replaced by this infiltrate, leading to myxedema. Clinical picture, goiter is lobulated, flat-topped nodularity, diffuse or localized, size large or small, consistency may be soft, rubbery or firm, initially mild hyperthyroidism but later hypothyroidism, investigations, elevated serum titers of antimicrosomal and antithyroglobulin antibodies, fine needle or true cut needle biopsy may be required to differentiate it from nodular goiter or carcinoma. Treatment, medical and surgical treatment. Medical for replacement dosage of thyroxine, while surgical treatment may be needed for large-size goiters, suspected development of lymphoma. Riddle's thyroiditis, etiology, autoimmune or collagen disorder, pathophysiology, hard woody transformation of thyroid tissue due to extensive fibrosis which extends even beyond the gland. It may occur in association with retroperitoneal fibrosis. Investigations, open biopsy to differentiate it from anaplastic carcinoma. It's rare, 0.5% of all goiter. Hypothyroidism is usually present. Simple goiter, endemic or sporadic goiter. Etiology, absolute or relative decrease in the circulating thyroid hormones leading to stimulation of thyroid gland by elevated levels of TSH. Due to iodine deficiency, whether absolute or relative, daily requirements of iodine is from 100 to 125 micrograms. Relative deficiency of iodine occurs during periods of stress. In Egypt, oasis areas are famous for endemic goiter. Type of the patient, females during menarche, pregnancy, and lactation. Enzymatic deficiency, this is responsible for many cases of sporadic goiter, often being associated with positive family history. Pendred syndrome due to deficiency of peroxidase enzyme which transforms inorganic iodides to organic iodine. Clinical picture, child has goiter, deafness, and muted. Several brothers or sisters are affected. This is for Pendred syndrome. Prognosis, liable to get recurrent goiter after surgery. Deficiency of dehalogenase enzyme is responsible for sporadic goiter. Goitrogens, intake results ultimately in goiter formation, includes thiocyanate in cabbages, drugs as para-aminosalicylic acid and antithyroid drugs. Stages of goiter formation, diffuse hyperplastic physiological goiter. Deficient synthesis of thyroid hormones lead to persistent elevation of the TSH, diffuse homogeneous hyperplasia of the thyroid gland. All follicles are active with uniform iodine uptake and is reversible on cessation of its stimulus, which is the increased TSH. Simple colloid goiter, etiology, iodine requirements are satisfied by large doses. Effect, follicles undergo involution or hyperinvolution where the follicles are distended with colloid and lined by flattened epithelium. Stage of nodular goiter, repeated fluctuations in the level of TSH due to repeated cycles of stress and strain, leading to heterogeneity of the gland with areas of active follicles and others with inactive follicles, recurrent hyperplasia and hypervascularity. Hemorrhages may occur, leading to central necrosis in the lobules. Most nodules are inactive. Active follicles are present in the internodular tissue. Other factors have been implicated in the etiology of nodular goiter, such as immunoglobulins, by acting on oversensitive cells and/or receptors, producing nodular goiter with marked heterogeneity of the structure and function between adjacent follicles. The condition appears early in endemic regions, but may be delayed to third decade in sporadic cases. Clinical picture, symptoms, cosmetic deformity, this is the main complaint. Sudden enlargement with appearance of pain and tenderness usually results from hemorrhage into a nodule. Some obstruction, respiratory. Signs, thyroid is firm, inconsistently with the nodular surface. The nodules are smooth, firm, and painless. Classification, hardness and irregularity, simulating malignancy. Complications, tracheal obstruction by compression. The tracheum may be compressed on either sides and becomes transformed into anteroposterior slit, scapular trachea. It may be compressed anteroposteriorly or displaced to one side by marked unilateral enlargement. In long-standing goiter, tracheal rings undergo chondromalacia and tracheal rings may collapse post-operatively. Malignancy, follicular carcinoma in 3%, secondary thyrotoxicosis up to 30%, cyst formation, hemorrhage into a nodule, classification in long-standing cases, and finally retrosternal extension. And then we have investigations. The patient is euthyroid. Thyroid functions to exclude mildly toxic nodular goiter and thyroid antibodies to exclude Hashimoto's disease. FNAC, fine needle aspiration cytology if a nodule is suspicious of malignancy. Prevention, using iodized table salt, potassium iodide, 1 part 10,000 has proved successful for prophylaxis in endemic areas. Regular follow-up. Treatment, there is irreversibility of multinodular goiter. Indications of surgical excision, partial thyroidectomy, if cosmetic reasons are present, and evidence of compression, mainly on trachea. Removing the nodular parts, leaving equivalent of 8 grams of relatively normal thyroid tissue, the size of a normal loop, on each side if feasible. Sometimes distribution of the pathology requires removal of the whole loop and subtotal excision of the other loop. Post-operatively, suppressive doses of L-thyroxine 0.1 to 0.2 mg per day to avoid recurrence in the remainder of the thyroid tissue. Surgery for multinodular goiter shouldn't be advised below the age of 25 unless very much indicated, as it may be followed by recurrence. Treatment of diffuse hyperplastic goiter, usually reversible by using L-thyroxine, usually 0.2 mg per day for several months to be tapered to 0.1 mg per day for several years. Retrosternal goiter, pathophysiology, divided into 3 types: plunging goiters, mediastinal goiters, and intrathoracic goiters. Plunging goiters rise with deglutition, descend again through the thoracic inlet, while mediastinal goiters, the whole goiter lies in the chest, but they are connected to the thyroid with a relatively narrow band of tissue and derive their blood supply from the thyroid vessels. Intrathoracic goiters, the whole goiter lies in the chest, completely separated from the main gland, independent blood supply from mediastinal vessels, not the carotid artery. Retrosternal goiters usually arises in normally placed thyroid glands. The sternohyoid, sternothyroid muscles prevent forward expansion assisted by gravity and negative intrathoracic pressure. They direct the swelling into the mediastinum. Clinical picture, type of the patient, more common in middle-aged men with short neck. Symptoms often remain symptomless for years, but it may develop dyspnea due to tracheal compression and worse at night. Character, spasmodic and positional, aggravated by any posture which reduces the thoracic inlet as lying down or flexion of the neck. Patients spend night in a chair. Dysphagia, signs, inspection, cyanosis of the face, superficial veins of the upper part of the chest are dilated due to innominate veins obstruction. Palpation of the neck may reveal enlarged thyroid gland. Percussion of the sternum may reveal retrosternal dullness. Investigations, plain chest X-ray shows a shadow in the superior mediastinum. Calcification often occurs in the walls of the goiter and may be demonstrated radiologically. 99 cm technician scan or thyroid scan reveals retrosternal extension. CT scan of the thorax will reveal the exact level of the retrosternal extension and its anatomic relations. Treatment, thyroidectomy is the only line of treatment. Resection is almost always possible by cervical approach. Rarely median sternotomy is required. Devascularization is done through the neck, from which the retrosternal portion derives its blood supply. Toxic goiter or thyrotoxicosis, hyperthyroidism, Common types: diffuse toxic goiter, primary toxic or Graves, which is 76%, toxic nodular goiter, secondary toxic or Plummer's disease, 14%, and toxic nodule, which is 5%. Rare causes of hyperthyroidism: we have thyrotoxicosis fastigia due to excess intake of L-thyroxine, more than 0.3 mg per day. Jod-Bizdow thyrotoxicosis occur in cases of hyperplastic endemic goiter upon administration of large doses of iodine. The condition is temporary and very rarely permanent. Subacute thyroiditis or Dicker-Vance disease. Mild manifestations of thyrotoxicosis may occur due to liberation of hormones from the destroyed tissue. Hashimotoxicosis. About 5% of patients with Hashimoto's disease may have hyperthyroidism in the early stages of the disease. Large mass of secondary carcinoma may be functioning. Neonatal thyrotoxicosis may occur in newborns. Thyrotoxic mothers or mothers with history of thyrotoxicosis due to transmission of thyroid antibodies across the placenta. The condition subsides in 3 to 4 weeks upon decline of the titer of the antibodies in the baby serum. TSH secreting adenoma of the pituitary gland. We have 2 notes. There may be multiple extrasystoles, paroxysmal atrial tachycardia, paroxysmal atrial fibrillation or persistent atrial fibrillation not responding to digoxin. In severe cases, proximal myopathy and muscle atrophy may occur. The proximal muscles, as the shoulder and pelvic girdle muscles, are particularly affected. Pathophysiology: diffuse toxic goiter, Graves' disease. Etiology: presence of thyroid-stimulating antibodies which combine with TSH receptors in the thyroid gland cells, leading to release of cyclic AMP activation and increased production of T4. Gross picture: diffuse enlargement of the whole thyroid gland. Microscopic picture: there is columnar proliferation of the epithelial lining of the acini, which may be arranged in several layers. The cells are columnar, full of granules. The acini contain less vacuolated colloid or are devoid of it. There is marked increase in vascularity and extensive lymphocytic infiltration. It affects mainly young females and usually of abrupt onset, characterized by remission and exacerbation. Toxic nodular goiter or Plummer's disease. Onset: insidious and may present with cardiovascular features. This occurs on top of long-standing simple nodular goiter, so it affects middle-aged and elderly persons. It's very rare, associated by extrathyroidal manifestations such as advanced exophthalmos. Is usually internodular tissue which becomes hyperactive, but occasionally one or more nodules becomes a site of hyperactivity. Autonomous toxic nodule. Toxicity is due to solitary hyperactive autonomous nodule. The toxic nodule produces suppression of TSH secretion with subsequent suppression of the remainder of the thyroid gland, which becomes almost atrophic, as evident on isotope scanning. Clinical picture: metabolic, loss of weight in spite of increased appetite. Patient complains of excessive sweating and intolerance to hot weather. The hands of the patient are moist and warm due to vasodilatation. Nervous system symptoms: nervousness, bad temper, insomnia, or bad dreams. Signs: the patient looks intense and irritable. There may be tremors in the outstretched hands. Reflexes: we have knee jerk, they are exaggerated. Cardiovascular system symptoms: the patient complains of palpitation even at rest. There may be anginal pain. If there is heart failure, the patient complains of orthopnea, pain in the right hypochondrium, and bilateral edema of the lower limbs. Signs: tachycardia with sleeping pulse more than 90 per minute, water hammer pulse due to high systolic due to increased cardiac output, and low diastolic pressure due to decreased peripheral resistance. Arrhythmias: all sorts of cardiac arrhythmias are present except for the heart block may occur. Muscular system: we have weakness with rapid exhaustion after minor effort. Skin: patchy pigmentation or vitiligo may occur. Pre-tibial myxedema presents as multiple orange-yellow patches of thickening of the skin over the shin of the tibia due to deposition of mucin-like substances. GIT: there may be diarrhea. Endocrine system: in females, menstrual abnormalities as menorrhagia, and in males, abnormal libido, gynecomastia, or impotence. Urinary system: polyuria or glycosuria. The eyes: mainly exophthalmos. We have true and false exophthalmos. True exophthalmos, characteristic of Graves' disease. It means actual protrusion of the eyeball due to deposition of fluid and round cell infiltrate in the retrobulbar tissues. The condition is aggravated by ophthalmic vein compression, leading to lead edema, conjunctival injection, and chemosis. False exophthalmos due to retraction of the upper eyelids and associated with diffuse and nodular toxic goiters. It's due to contraction of the levator papillae superioris, molars muscle. The high level of thyroid hormone sensitizes this unstriated muscle to the effect of circulating catecholamines. Beta-adrenergic blocking drugs as guanfidine eye drops improve the false exophthalmos. Eye signs other than exophthalmos, they are Daremper's sign, Stilbach signs, von Graffi sign, Geoffroy's and Mobius sign. Daremper sign, appearance of a rim of sclera between the upper eyelid and the cornea. Stilbach sign, staring look with infrequent blinking. Von Graffi's sign, the upper eyelid lags behind moving eyeball as the patient looks down without moving the head. Geoffroy's sign, lack of forehead wrinkling on looking upwards without moving the head. Mobius sign, defective convergence due to muscle paresis. Weakness of extraocular muscles results in diplopia. In severe cases of papilledema, corneal ulceration and optic nerve neuropathy may occur. The severe progressive form is known as malignant exophthalmos. It's known that true exophthalmos is an autoimmune disease due to thyroid-stimulating antibodies affecting the ocular muscles. False exophthalmos usually disappears when the hyperthyroidism is treated. Neck. In diffuse toxic goiter, the thyroid gland is diffusely enlarged and soft. A thrill and bruit may be detected at the upper pole over the superior thyroid arteries. The surface of the gland is smooth and the overlying skin is warm. The gland may show expansible pulsations. In nodular toxic goiter, the thyroid gland is firm in consistency with nodular surface. The size of the gland may be large. Most, but not all, symptoms and signs of thyrotoxicosis are due to excess thyroid hormones. Many systems are vulnerable to these hormones. Diagnosis, mainly by clinical examination. Thyrotoxicosis should be suspected in children with growth spurt, behavioral problems, or myopathy, elderly person with unexplainable tachycardia or arrhythmia, apathetic hyperthyroidism, unexplained diarrhea or weight loss, resistant heart failure, have marked thyrotoxicosis. So we have comparison between Graves' disease and toxic nodular goiter. According to the age, Graves young, while toxic nodular goiter is elderly onset, abrupt in Graves, while gradual in toxic nodular goiter, course in Graves, exacerbation and remission, whilst it's steady in toxic nodular goiter. Nervous system is more affected in Graves. Metabolic manifestations are more in Graves than toxic nodular goiter. Cardiovascular manifestations are more in toxic nodular goiter than in Graves. Eye signs are present in Graves' disease, and we have exophthalmos, while there is no exophthalmos in toxic nodular goiter. Thyroid show diffuse enlargement and soft and vascular in Graves' disease, while in toxic nodular goiter, multiple or solitary nodules. Investigations: thyroid function test T3, T4, TSH, iodine 123 uptake test to confirm the diagnosis. T3 thyrotoxicosis identified by elevated free T3. Toxic adenoma shows as hot nodule on iodine 123 scanning with suppression of the uptake of the surrounding thyroid tissue. Treatment: we have medical and surgical and radioactive iodine. Medical indications: primary thyrotoxicosis, mild thyrotoxicosis, children and young patients because surgery may affect their growth, pre-operative preparation and post-operative recurrence, small gland and refusal of surgery. Advantages: it avoids surgical risks and avoid the possible hazards of radioactive materials, but the disadvantages are: there is no way to accurately predict which patient is liable to pass into remission, high relapse rate, which accounts for 60% within 2 years from stopping the treatment, further enlargement of the gland may occur. Adverse effects of the drugs thiuracil and carbimazole may cause gastrointestinal upset, rashes, arthralgia, and reversible bone marrow depression, leading to agranulocytosis. Types of the drugs used: carbimazole, propyl thiuracil, potassium perchlorate, propranolol or other beta-adrenergic blockers, and iodides. Carbimazole action: it blocks iodine binding to tyrosine and decreases antibody titers, and it's most commonly used drug in Egypt. Dose: the initial dose is 10 mg 3 times daily with maximum dose of 60 mg daily. Effectiveness: there's latent interval of 7 to 14 days before clinical improvement takes place. When the euthyroid state is reached, the dose is gradually reduced to 5 mg 3 times a day and maintained to 12 to 18 months. Propyl thiuracil action: it blocks iodine binding to tyrosine and prevents peripheral conversion of T4 to the more active form T3. Dosage: 100 mg 3 times per day. Potassium perchlorate It competitively inhibits iodide uptake by the thyroid. Propranolol or other beta-adrenergic blockers action. It inhibits cardiogenic effects of the thyroid hormones by beta blockade, and it mustn't be used in asthmatic patients. Iodides action. They reduce the effect of TSH on the thyroid gland and inhibit iodine binding. They reduce vascularity of the thyroid gland and leading to storage of colloid within the athenae. Their effect is only temporary and they cannot be used for long-term control. Their main use is for preoperative preparation. Radioactive iodine, mechanism of action, it destroys the thyroid cells, so it reduces the mass of functioning thyroid tissue. Dosage is 160 UCI per 1 milligram of thyroid tissue. The response is usually slow. Improvement is expected after 8 to 12 weeks. If not, a second dose or several doses may be required, which is the case in 20 to 30% of those patients. Indications: diffuse toxic goiter, thyrocardiac patients, refusal of surgery, recurrence after surgery, and solitary nodule. The minimum age for its use in many centers is now 25 years, inadequate for the treatment of secondary toxic goiter as most nodules have low iodine uptake. They show cold nodules in the thyroid scan. Advantages: it avoids surgery or prolonged medical therapy. Disadvantages: progressive destruction of the gland resulting in thyroid insufficiency, iatrogenic hypothyroidism in up to 75% to 80% of cases after 10 years, and so indefinite follow-up is mandatory. Radioactive iodine treatment has long been blamed for causing genetic damage, leukemia, damage to the fetus if administered in early pregnancy, increasing the incidence of thyroid carcinoma in adults 10 to 15 years after its administration. Surgical preparation: usually carbimazole and propranolol are satisfactory. Some surgeons recommend prescribing iodized lugos iodine 10 drops 3 times per day for 10 days preoperatively to diminish the vascularity of the gland and render it more firm. Indications: secondary toxic goiter, severe primary thyrotoxicosis, retrosternal toxic goiter, failure of medical treatment, occurrence of side effects due to medical treatment. Sleeping pulse of 80 per minute is considered as effective preoperative preparation. The patient should be in euthyroid status before undergoing the operation, otherwise he may develop post or intraoperative thyroid crisis. Advantage of the surgical procedures: rapid cure and high rate of success. Disadvantages: morbidity, mortality, recurrence rate less than 5%, thyroid insufficiency at an incidence 20 to 45%, parathyroid insufficiency in less than 0.5%, but it's a definite risk even in inexperienced hands because of the high incidence of anatomical variation of the site of the parathyroid glands. And this concludes our part for today for the thyroid. Special problems in management: proptosis of recent onset is not preferable to terminate the toxic status abruptly by surgery or radioiodine for the fear of theoretical risk of progressing of malignant exophthalmos. Antithyroid drugs are used until proptosis has been stable for 6 months, after which total thyroidectomy is recommended. Parotoxic cardiac patients: the cardiac condition takes priority in management. Thyroidectomy is ideal after controlling cardiac status. If not permissible, radioiodine is used, followed by antithyroid drugs until the effect of the former appears 6 weeks. Thyrotoxicosis in children: radioiodine is contraindicated for children. Conventional surgery is followed by high recurrence rate due to high activity of the cells in the young, or followed by hypothyroid state, which affects later growth. Prefer to tide them by antithyroid drugs till late teens. Thyrotoxicosis with pregnancy: radioiodine is absolutely contraindicated because it may result in the destruction of the fetal thyroid. Antithyroid drugs at conventional doses would cause fetal hypothyroidism, resulting in goiter, which may obstruct the airway. Management: in order to reduce this risk, minimal doses of antithyroid drugs supported by beta blockers. The dose of an antithyroid drug is adjusted according to the serum level of free T4. Surgery after a 4th course of antithyroid drugs and propranolol proved to be safe during the 2nd or 3rd trimester. During lactation, propylthiouracil is recommended as it's excreted in a harmless, very low concentration in milk. Hypothyroidism: etiology: failure of development of thyroid gland, dyschromogenesis, congenital deficiency of one of the enzymes responsible for the formation of thyroid hormones, such as peroxidase enzyme, failure of secretion of TSH by the anterior pituitary in Sheehan syndrome. Primary myxedema: an autoimmune disorder. It may be associated with Addison's disease. Iatrogenic, followed by subtotal thyroidectomy or radioactive iodine treatment, particularly for toxic goiter in late stages of Hashimoto thyroiditis. Clinical picture: Hypothyroidism in infants or children leads to cretinism, while in adults it leads to myxedema and is applied to severe cases of hypothyroidism. Symptoms: cretinism, all the parameters of normal development are impaired, the infant doesn't grow properly, he is stunted, delayed teething or walking, the child has an apathetic look with depressed nose, thick lips, and thick protruding tongue, the abdomen is descendant, pot belly, and there's usually an umbilical hernia. Myxedema, the patient complains of lethargy, weakness, loss of appetite, putting on weight, and intolerance to cold weather. Signs: the patient looks apathetic with prolonged reaction time, the face is puffy with supraclavicular pads of fat, the skin and hairs are dry, furthermore the hands are cold, there is bradycardia with low volume pulse, the voice of the patient is coarse, pericardial effusion, deafness and ataxia may be present. Complications: coronary thrombosis due to hypercholesterolemia. Patient, if subjected to a stressful situation, may develop coma, myxedema coma. Investigations: T3 and T4 levels are low, TSH markedly raised, and treatment: adults, replacement by L-thyroxine 0.2 to 0.3 milligrams per day. For children, very early treatment is a must, otherwise changes are irreversible. Thyroid neoplasms classification: tumors arising from follicular epithelium, tumors from parafollicular epithelium, tumors from lymphoid elements, and rarely the thyroid gland is infiltrated by metastatic deposits or by local infiltration from a nearby lesion. Tumors arising from follicular epithelium: benign follicular adenoma, malignant, differentiated, such as papillary carcinoma, follicular carcinoma, and mixed carcinoma; undifferentiated, anaplastic carcinoma. Thyroid has two types of cells, follicular and parafollicular cells, so tumors from the parafollicular epithelium is medullary carcinoma, and tumor from lymphoid elements, malignant lymphoma. Follicular adenoma present as solitary nodule. The main concern is to differentiate it from follicular carcinoma, which may have the same clinical picture. The main differentiating point during histopathological examination is to detect evidence of capsular or vascular invasion as carcinoma. That's why needle aspiration cytology is not a reliable test in this condition. Treatment: lobectomy of the side of the adenoma plus isthmectomy. Predisposing factors: external irradiation of the head and neck region in children, which was previously used for treatment of hemangiomas and thyroid gland enlargement. Follicular carcinoma is a common type to develop in endemic goitrous areas, possibly due to continuous stimulation of thyroid gland by TSH. Genetic element may be present as the lesion is more common in certain families. Malignant lymphoma may occur on top of Hashimoto disease. Types: we have comparison between papillary, follicular, and anaplastic type. For the papillary carcinoma incidence, 60 to 70%. Age: children. Sex: for female to male ratio 3.5 to 1. Multiplicity up to 80%. Microscopic picture: papillary projections formed of connective tissue covered by a single layer of epithelial cells with pale empty nuclei. Laminated calcified bodies, samoma bodies, are often present. Spread: mainly lymphatic, and the 10-year survival rate is 90%. For the follicular type, incidence 17%. Age: adults. Female to male ratio 2 to 1. Multiplicity is rare. Microscopic picture: thyroid follicles with variable degree of differentiation. Solid sheaths may be present. Diagnosis depends on finding capsular or vascular invasion or on detecting metastasis. Spread: mainly by blood. 10-year survival rate: encapsulated 97%, and for invasive 70%. For the anaplastic carcinoma, incidence 1 to 5%. Age: elderly. Female to male ratio 1 to 1.3. Microscopic picture: may take the form of spindle cell or large cell type. Spread: mainly direct. Most patients die within 1 to 2 years. Medullary carcinoma: this tumor accounts for about 6% of malignant neoplasms. The tumor arises from the parafollicular cells and therefore considered a part of the apodomus. It secretes calcitonin. The tumor may occur alone, or it may be associated with hyperparathyroidism and pheochromocytoma constituting MEN2A. The tumor may be familial, and in this case it's more common in children and young adults. Genetic testing or RET proto-oncogene is recommended. Microscopically, the tumor is composed of sheets of neoplastic cells set in hyaline stroma, which may contain amyloid material. Mitotic rate of growth is usually low. It may spread to lymph nodes in 50 to 60% of cases or give rise to blood-borne metastasis. If the histopathology contains both papillary or follicular elements, it's managed as papillary. Features of papillary carcinoma considered high risk and associated with worse prognosis, including male gender, primary tumor size more than 4 cm, gross local invasion, or extrathyroidal extension, age more than 45 years, certain histological subtypes, specifically the tall cell variant, lymphovascular invasion, or known metastatic disease. Clinical picture, symptoms, thyroid swelling which is enlarging rapidly over some months. Sometimes the swelling is painful and the pain may be referred to the ear. Referred along the articular branch, Arnold branch of vagus, auricular branch, not articular. Compression manifestations. If the lesion is advanced, the patient may complain of dyspnea or change of voice due to involvement of the recurrent pharyngeal nerve. Any slit nodule of the thyroid, especially in young males, is suspicious. Signs: a lump, firm to hard in consistency, occupying part of the whole thyroid gland. There may be some restricted mobility of the thyroid. In anaplastic tumors, the rate of growth will be more rapid and there will be early infiltration of the surrounding structures as trachea, recurrent pharyngeal nerve, or the muscles. Lymphatic or blood-borne metastases, the latter occur usually in the bones, particularly the spine, skull, or neck of femur, in the lungs, or in the brain. Medullary carcinoma may produce diarrhea in 30% of cases due to production of high hydroxytryptamine or prostaglandins. Occult carcinoma, some patients may present by metastatic lymph nodes in the jugular chain, while the primary papillary carcinoma is not palpable. Investigations to diagnose: we have ultrasound, can prove whether the lesion is cystic or solid. The following ultrasound features are suggestive of malignancy: hypoechoic, uneven borders, irregular, increased vascularity, microcalcification, metastatic lymph nodes, and size more than 1 cm, many benign lesions as cysts or thyroiditis or degenerative nodules or hemorrhage. In the cyst appear also as cold areas. Thyroid isotope scanning, limited diagnostic significance because of the mentioned reason. Malignant lesions usually appear as cold areas in the scan. Aspiration of a cyst. We have difference between benign cyst and malignant cyst. Benign cyst, we have clear aspirate, complete disappearance, fluid in cyst, no reaccumulation, and cytological exam is free. Malignant cyst is positive for malignant cells, and we have rapid reaccumulation of the fluid, residual lump in appearance, and hemorrhagic aspirate. Fine needle aspiration cytology, FNAC advantages: simple, rapid, inexpensive, and experienced pathologists can give accurate result in about 90%. Disadvantages: in follicular carcinoma, FNAC may be not conclusive as the diagnosis of this lesion depends upon demonstration of capsular or blood vessel invasion, not depending on cellular atypia. Surgical exploration: if the diagnosis is still in doubt with complete resection of the affected loop, it's recommended to do frozen section so that definitive treatment is performed simultaneously. For staging: chest X-ray to detect pulmonary deposits, indirect laryngeoscopy for the mobility of the vocal cords. For follow-up tumor markers, estimation of serum calcitonin is raised in many patients with medullary carcinoma considered as a tumor marker. Thyroglobulin is a tumor marker for differentiated thyroid carcinoma. Thyroid hormone suppression therapy: we have initial TSH suppression below 0.1 milliunit per liter, and lifelong TSH suppression at or below the lower limit of normal, 0.1 to 0.5 milliunit per liter. Treatment: differentiated carcinoma. Total thyroidectomy and post-operative replacement therapy is recommended because high incidence of multicentric lesions in papillary carcinoma. Total thyroidectomy ablates in all thyroid tissue and makes it possible to detect metastases by scanning and to treat them by radioactive iodine, which is not possible in the presence of normal thyroid tissue. L-thyroxine 0.2 mg per day prescribed to suppress TSH production, as most differentiated carcinomas are TSH dependent. Post-operative thyroid scan to detect any residual lesion, which, if present, is treated by ablative dose of radioactive iodine. Aim: to decrease recurrences and may improve survival. Methods: oral levothyroxine is started at a dose of 1.4 gram per kilo per day. Adequacy of thyroid hormone replacement is assessed by measuring TSH every T4 6 to 12 weeks after initiating therapy. Management of lymph node metastasis: if there is no palpable metastatic deposits, follow-up is needed for the central lymph nodes because they are excised, especially in high-risk group. If there are metastases in the posterior triangle, modified block dissection performed in which accessory nerve, internal jugular vein, and sternomastoid muscles are preserved. Management of blood-borne metastasis: thyroxine is stopped for a few weeks or substituted by triiodothyronine to raise TSH, then iodine scan is performed. If there is evidence of local recurrence or metastasis, then therapeutic doses of radioactive iodine are prescribed. Medullary carcinoma doesn't concentrate radioactive iodine and is not under the control of TSH. Treatment by total thyroidectomy and resection of metastatic lymph nodes. Anaplastic carcinoma. The majority of the patients are inoperable. The usual treatment is external irradiation and chemotherapy. If there is tracheal compression, the isthmus is resected. Malignant lymphoma, radiotherapy, and chemotherapy. In patients with palpable primary tumors, additional dissection of ipsilateral lateral compartment nodes should be performed. Total thyroidectomy alone is indicated only for men. 2. Patients who have thyroid nodules less than 5 mm and calcitonin levels less than 40 pg per liter. There are certain factors which worsen the prognosis, such as age, size, and presence of capsular or blood vessel invasion. Age, males above 40 and females above 50 years of age, and size of the lesion is more than 5 cm in diameters. Solitary thyroid nodule. Findings that raise suspicion of malignancy: history of irradiation, young, elderly, recent onset and rapid growth, pain. The nodule is hard, irregular with limited mobility, local invasion or lymphatic or blood-borne metastasis. Differential diagnosis: the nodule may be a part of multinodular goiter. Other nodules are not palpable. Commonest: toxic nodule, colloid nodule, adenoma, and carcinoma. Investigations: thyroid function test and thyroid isotope scan is performed if there is suspicion of toxicity. Ultrasound may differentiate between a cyst and a solid lesion. Fine needle aspiration cytology. This is a simple, fast, and inexpensive investigation. Depends upon cytological examination of nodules 0.5 cm or more. True cut needle biopsy. It may cause hematoma. Obtain a core of tissue for histological examination of nodules 2 cm or more in diameter. Excision biopsy. The surest sign of diagnosis is to do lobectomy, not inoculation of the affected site, and perform frozen section histological examination in suspected cases. Management. Algorithm for the management of solitary thyroid nodule. Thyroid nodule clinical evaluation plus thyroid function tests and isotope scan. If toxic nodule, surgery. If euthyroid, we perform ultrasound. If solid, we go for ultrasound guided FNAC, fine needle aspiration cytology. And if cystic, we do aspirate. The aspirate can be benign, suspicious, or malignant. If suspicious, it can be follicular neoplasm. We observe or perform lobectomy or total thyroidectomy, and the solid can be benign or suspicious or malignant. And this concludes our part for the thyroid gland.